Working as oncopathologist and associate professor at Pacific Medical College and Hospital, and my topic for presentation today is Indian data on HER2 fluorescence in situ hybridization in invasive breast cancer with immunohistochemically equivocal results or as per 2018 ASCO CAP guidelines. This paper, I am presenting the data from this paper, which was published in the year 2022 in South Asian Journal of Cancer. So as you all know, hormonal status and HER2 expression are mandatory as they dictate further treatment and prognosis. And the American Society of Clinical Oncologists and College of American Pathologists, they together introduced the guidelines for HER2 immunofluorescence reporting as immunohistochemistry reporting and interpretation in the year 2007, which was further modified in the year 2013 to include HER2 FISH reporting, as there were many HER2 equivocal cases on immunohistochemistry. So to cut down those cases and to come to a final diagnosis, they had introduced HER2 FISH so that maximum number of cases would be benefited by anti-HER2 targeted therapy. Following which, the number of HER2 equivocal cases by FISH, they were challenging, as there were no definite guidelines as to how to treat those cases which fell into HER2 equivocal category by FISH. So in that case, ASCO CAP, they revised the guidelines in the year 2018 to limit this HER2 equivocal category, and they further classified into they classified the HER2 FISH in 5 groups, and based on that, they were definitely categorized into either positive or negative category instead of putting it into HER2 equivocal category. So this is how IHC reporting for HER2 is done. Score 0 and 1 plus are negative, and score 3 plus is positive, while score 2 plus is falls into equivocal category. For all these equivocal cases, we need to do HER2 FISH by validated dual probe-ish assay, and based on the ratio of HER2 and chromosome 17 ratio signaling, we categorize these into 5 groups, group 1 to 5, and when the HER2 CP ratio is more than 2 and the average HER2 copy number is more than 4 signals per cell, this is ish positive, which falls into group 1, and when the ratio is less than 2 and the signals per cell, HER2 signals per cell is less than 4, it falls into ish category, group 5, which is negative. In the intermediate groups, there are group 2, 3 and 4. Group 2 is HER2 CP ratio more than 2, while the HER2 signal per cell is less than 4. Group 3 is ratio less than 2 with signals more than 6, and group 4 is ratio again less than 2, while the signals are more than 4 and less than 6. So these are the 3 groups wherein we need to do concomitant IHC analysis to come to a final diagnosis. Here is the ASCO CAP guidelines, which categorize these groups. So group 1 is positive and group 5 is negative, whereas when it's group 2, 3 and 4, we have to look at the HER2 IHC profile, and if it's definite 3 plus on IHC, then it's positive. We have to consider it to be HER2 positive, and anti-HER2 therapy can be given in these cases. In group 3, if it's equivocal also, then we should also consider it to be positive and anti-HER2 therapy can be given. While if it's 0, 1 plus or 2 plus on IHC, then these group 2, 3, 4 should be categorized as negative. So the purpose of the study was to evaluate IHC equivocal cases and compare the findings with FISH results, and to assess the revised 2018 guidelines that affected the final HER2 status. So this was a retrospective study wherein 502 cases of invasive breast carcinoma were included, which was reported equivocal on IHC, and the duration of the study was from January 2016 to January 2022, and FISH was performed using Cytovision HER2 dual probe kit on interface invasive tumor nuclei on formalin fixed paraffin embedded tissue. And FISH results were interpreted based on both 2013 and 18 guidelines, and the change in the number of final results were studied. So the sample were collected from all primary site, metastatic site, and even in the recurrent cases. So 458 cases were from primary site, 36 were from metastatic site, and 8 cases were from recurrent site. Histomorphologically, maximum cases were diagnosed as invasive ductal carcinoma, followed by invasive lobular carcinoma. Apart from there were mucinous carcinoma, cribriform carcinoma, and various other carcinoma, which accounted for less than 1%. So with the implementation of 2008 guidelines, the interpretation of HER2 status by FISH changed for 27 cases, which is 5.4%, and the cases that were unchanged according to both 2013 and 18 guidelines were around 258 HER2 positive and 217 HER2 negative cases. In these, it was clear-cut positive or negative according to both 2013 and 18 guidelines, while the equivocal cases which were reported as positive equivocal in 2013 according to 2013 guidelines, which fell into category of group 4 by ISH, these were scored negative by 2018 guidelines. Like these cases were interpreted as equivocal by HER2 FISH according to 2013 guidelines, but 2018 guidelines, it was finally diagnosed as negative. And 2 cases which were diagnosed as HER2 positive as per ISH 2013 guidelines were scored as negative following this 2018 guidelines, and they fell into category group 2. Overall findings of the 502 invasive breast carcinoma cases according to 2018 guidelines were 219 cases were classic amplified, that is positive, which fell in group 1. 217 cases were classic non-amplified, which is negative, fell in group 5. And 2 cases which fell in group 2 were ultimately given as negative. 39 cases belonged to group 3, which were positive, and 25 cases were in group 4, which were negative, but they were given equivocal according to 2013 guidelines. So with the updated 2018 ASCO CAP guidelines, the interpretation criteria for HER2 status was based on both HER2-ish and IHC reporting. We need to go look at both IHC and FISH for a conclusive report. And according to data based on this study, 2 cases fell in group 2, 39 in group 3, and 25 cases in group 4, which totally accounted for 13.1 cases according to this study based on Indian data, while according to the international data, 5% of breast cancer were reported to fall in these categories, group 2 to 4, which is the equivocal or dicey category, where we need to look at IHC for confirmation. ISH2 group is uncommon, and here in this study also there were only 2 cases reported, and which is similar to other studies, and these cases were reported as HER2 positive as per 2013 guidelines, but according to 2018 guidelines, they were it was in the clinical trials, it was found that they did not show significant effect on patient following anti-HER2 therapy. So the 2018 guidelines classified them into negative category. So whenever there any HER2 FISH reporting falls in group 2, we need to do a blinded ISH scoring by a second pathologist counting at least 20 cells. And then if the results are similar, then it is categorized as HER2 negative, while if there's different ISH result, then the internal procedure for FISH testing should be validated. 39 cases fell in category ISH group 3, and these findings were variable among different studies. The positive rate for IHC in this category, group 3 category, were from 8.3 to 75%, and there were marked variability in these studies across various different laboratories. And considering the heterogeneity of HER2-ish IHC results, 2018 guidelines recommend that whenever there's this group 3 with either score of 2 plus or 3 plus on IHC, these should be categorized as HER2 positive. 25 cases fell in category group 4, and this was similar to the data obtained from an international study performed by Wong et al. And here they say that CP17 copy number gain is a genetic change which is commonly seen in dual probe HER2-ish for breast cancer, and which is reported to with a frequency of 3 to 46% in invasive breast cancer. So if chromosome 17 is monosomy or there is polysomy of that, then it may affect the ratio of the HER2 chromosome CP17 ratio. So according to 2013 guidelines, they said that chromosome 17 we could use some other alternate probe for CP17, but 2018 guidelines have denied it, and they say that there are no clinical trials supporting this change of probe, and there is no advocated use of any alternate probe to identify true polysomy due to limited evidence on both analytical and clinical validity. So there's no use of using an alternate probe for chromosome 17 to come to a diagnosis. Tumor heterogeneity is a very big problem, because these tumor with HER2 heterogeneous areas more commonly fell in equivocal HER2 expression cases, and studies have found that the patients with HER2 heterogeneity have incomplete response to targeted therapy and decreased disease-free survival. So it is prudent to know that while assessing receptor status change by FISH after chemotherapy at metastatic sites, evaluation of dual-ish report should be done concomitant with IHC review. It is mandatory to compare both of them together to come to a diagnosis in those heterogeneous areas. Data from this study depicts 5.4% increase in HER2 negativity rates, because here the group 2 and group 4, which were given as equivocal and positive on the 2013 guidelines, based on 2013 guidelines, were finally classified as negative according to 2018 guidelines. So the number of reported HER2 negative cases had increased following these 2018 guidelines, and FISH results are more definitive in treatment making in this 2018 guidelines according to 2018 guidelines, because the equivocal category is removed. Thank you.
Category will add the challenges for pathologists to give the right answer. So how will you ensure quality assurance for HER2 low category?
For HER2 low category, according to 2018 guidelines, like we have to look for FISH and IHC both, and we have to see for the tumor areas like on morphology whether it's high grade or this metastatic site, and we have to look for all those areas and then decide which area should be taken for diagnosis, because invasive breast cancer in high grade and those which mostly will be HER2 positive. So we have to do a simultaneous-ish and IHC study to come to a diagnosis.
Can I also ask you a question? Like, we are always worried and upset. We are using a molecule which is extremely expensive.
Yes, sir.
And for one lab we get a HER2 negative or 1 plus, and from another lab, same tissue, we get a HER2 of 3 plus by IHC. So is there some standardization exercise going on amongst pathology labs in, say, Udaipur and Jaipur in our country, or Is it just arbitrary? And my second part of the question is, what is the concordance rate between labs in, say, Udaipur, Jaipur, Delhi, Bombay?
Sir,
Honest opinion. Huh? This is like a closed group.
okay, sir. Sir, this HER2 reporting depends very much on the fixation time and the cold ischemia time, that is from when the tissue is collected from the body and put in formalin. So on that time, fixative type. So all those things affect a lot on the IHC results. So it depends on the lab, like how they are performing, how they are pertaining to those strict conditions, whether proper fixative is used or not. And also the staining, there are many false positive and false negative cases based on the staining, like how much probe is added and then how much nuclear stain is done. So based on that, there can be variation. So every lab need to standardize it and look at the external quality control should be done apart from the internal quality control. So I don't know the data of Jaipur. Like Udaipur, we hardly do in some hospitals only HER2 IHC, and fish it's sent outside to outside labs.
Yeah, so I think it's time that oncopathologists and oncologists leave aside the government. The government will do whatever they want to do when they want to do. Maybe we should start a quality confirmation exercise, no?
Yes.
And you guys should take a lead in that, right?
Hi, Kavita. Nice presentation.
Thank you.
My suggestion, again, I'm not a pathologist, that there's no uniform policy of fixation of tissue.
Yes.
I think you guys should take that upfront and try to have at least uniform policy in Udaipur.
Yes.
That is the way we should have a specimen safety, fixation, time of, transfer from OT to pathology lab. Just a suggestion. Maybe that will improve a lot of quality.
Yes, ma'am.
So I think what Garima is saying is very important. The first step is how should the surgeon preserve the tissue and send it to the pathologist. And we some time back got the Roche company to make posters, and we had these posters put in the operation theatre of at least our hospital, at SMS hospital. So in all the OTs, general surgery as well as onco surgery, we had these posters put, and it made a big difference.
Yes,
So I'm sure the Roche people will be able to, or somebody else will be able to provide you these optimization posters, which anybody who is doing breast cancer surgery, his or her OT must have this poster. And of course it should be followed.
Yes, sir.
Only poster may not help in our situation. Private medical colleges, you will see every day new ward boy, new person coming to the, taking care of the specimen. So I think surgeons should be updated, and so is pathologists should insist that these are the guidelines, you
Yes,
should
ma'am.
follow it, otherwise
Many a
report will
times,
not be. Yeah.
Yes, ma'am. Many a times we receive specimen in normal saline, like after
That's what I'm
2-3
saying.
hours we receive in normal saline.
That's what I'm saying.
And then we change in the lab. So that has definitely affected already the cold ischemia time.
You-
so
you
in
c-
that case,
Yeah, you can see there is a difference between 2013 and 18 guidelines. So everything is changing very fast,
yes,
and surgeons are a little slow learner.
Apologies, ma'am. Due to want of time, we'll have to move to the next
Just
talk.
one comment I want to give. I'm a pathologist working at Core Diagnostics. So my experience is external quality assurance program should be taken wherever the HER2 is or ERPR testing is being done. It is very, very necessary. Like we are a CAP accredited and enable accredited lab. And we are periodically taking the CAP surveys, and we are, whenever there is any failure in the survey, we do a corrective action that takes care of this quality assurance.
Thank you, ma'am.
So apologies to everyone. Due to want of time, we'll have to move on to the next talk. I now invite Dr. Mallika Dixit, hemato and lymph node pathologist from Gurugram, to please deliver the talk on role of CTC in determining prognosis in MBC. Over to you, ma'am.
Very good morning to everyone, and thank you, Dr. Manoj, for giving me this opportunity to be here in Udaipur. So, topic of my talk is role of circulating tumor cells in determining the prognosis in metastatic breast cancer. A very interesting, though you can say a very controversial too. So tissue biopsies versus liquid biopsies. When do we need to do a liquid biopsies? Though the tissue biopsy still remains the gold standard for the diagnosis, staging, IHC, and characterizing for the tumor and molecular testing. But at times, what we see in our routine practice is after doing the IHC, the tissue got depleted, and by the time it reaches for the molecular testing, very less tissue is there. Whether the minimum requirement for the molecular testing is 15% of the tumor is required, which is not there. At times, there is no viable tissue is in the block. So all these factors lead, and the patient is medically unfit to get rebiopsied, and there is a delay in the expected start of the treatment. In such cases, liquid biopsies, we should go for the liquid biopsies. So tissue biopsy is basically invasive and a painful procedure with increased risk and difficult to repeat. Liquid biopsies is a non-invasive, less painful, with less risk to the patient. But however, it lacks the standardization and mainly used in the traditional research processes. It represents, there is a tumor, as Dr. Kavita has also said, tumor heterogeneity is there in the tumors. So this is a factor for IHC and molecular testing when we perform it in the tumor tissue, on a block, on a solid tissue. Wherever this tumor heterogeneity is being well taken care of by the liquid biopsies, because these cells can be from the metastatic site as well as from the primary tumor, and it serves as a real-time monitoring of the disease, and whereas the tissue biopsy is just a snapshot over the time. So there is a varied modalities for liquid biopsies, but I would be confining myself to CTCs and ctDNAs. CTCs and ctDNAs are defined as the cancer cells, a cell-free DNA shed from the primary tumor and are circulating in the bloodstream, saliva, effusions, or CSFs. Plasma is the preferred source in the case of ctDNA. It offers a non-invasive approach, and it serves as a primary tumor heterogeneities and genetic alterations are preserved in it. There are some pros and cons to it. The pros are it leads to the early detection of cancer, significant information on therapeutic targets and resistance mechanism. Real-time monitoring of the tumor can be done. And the cons is there is a lack of standardization of the CTC isolation and enrichment platforms, and there is no harmonization is there among the different laboratories, and further studies need to be done. The cells have a short half-life and show the low detection rate, and the long-term preservation as the seen in the tissue sample is not there in the liquid biopsies. So this is a photograph showing the process of how the CTCs are being isolated. There are two processes based on the physical properties and on the immunoaffinity process based on the magnetic beads. So till now, till date, there is only one FDA approved system, that is cell research system, and which is being this uses the enrichment method of anti-CD45 coated magnetic beads, which excludes the CDWBCs, and we are left out with the cell of interest, that is the cancer cells, which are being further enriched by the EpChem magnetic beads and then further stained with CK8/18. So according to cell search definition, CTC is any intact EpChem positive, CK positive, CD45 negative cell, at least 4 micrometer in size, with the nucleus occupying at least 50% of the cytoplasm. Now, what is the difference between the CTCs and ctDNAs? This is ctDNA is being obtained from the fragmented genome, which is released from a necrotic and apoptotic cells in the blood circulation, and the mainly analyzed DNA by the process of NGS. And in CTCs, this is a real-time monitoring of the tumor cells, and other DNA, RNA, and protein functionals can be studied, and it provides the estimation of risk of metastasis relapse and metastatic progression. Stratification and real-time monitoring of therapies can be done. Identification of therapeutic targets and resistance mechanism can be well studied, and understanding the metastatic development in patients with cancers can be done. And also the NCCN guidelines version 3 to 2022 has also included this plasma testing by for the molecular testing if the tissue sample is not available. So I would be discussing a role of circulating tumor cells in determining the prognosis in metastatic breast cancer. This is a paper by Dr. Dinesh and Dr. Anurag Mehta from Rajiv Gandhi Cancer Institute, recently published in the South Asian Journal Cancer. And this study was conducted to assess the role of CTCs and to determine the prognosis in terms of survival in the metastatic breast cancers. The method, it is a prospective study. 36 patients were enrolled with clinically and radiologically proven newly diagnosed cancer, metastatic breast cancer, with no history of prior treatment or cancers were included in this study. And the other comorbidity situations and malignancies were excluded from the study. Details of the patient, demographic profile, investigation, tumor types, histopathology, treatment follow-up information were recorded. Pathological diagnosis was confirmed by biopsy. Distinct metastasis was done diagnosed with the appropriate imaging modalities. All the patients underwent the PET scan after 3 months and after the 6 months after the starting. The number of CTCs in the peripheral blood was measured before giving the chemotherapy and after the first cycle and after the 6 months of starting the chemotherapy. And the integrated CTC analysis system, CELSI PrEP 4000, was used for this process. So this is a demographic table depicting the demographic details of the patient. Mean age was 50.1 years. Both the pre-menopausal and post-menopausal were 50-50%. 50% of the cases fall in the ECOG group 1. ER positive status was present in 56% cases. HER2 negative were 53% cases, and low to moderate grade was seen in 55% of the cases. All the patients were in the phase initiating their first line of therapy for metastatic breast cancer, and docetaxel and the epiribicin was the most commonly used regimen in this study, 42%, followed by docetaxel, carboplatin, and trastuzumab with or without pertuzumab in HER2 new positive patients. And rest of the patients were given paclitaxel alone or these two drugs alone. Before the evaluation at 1 year, 8 patients were withdrawn from the study. 3 of these were lost to follow-up and 4 died. And 1 had a severe cardiac symptoms and stopped the treatment. Lymph node was the most common site of metastasis, 86%, followed by lung, liver, bone. 22% had 3 or more metastases. Coming to the results, all the 36 patients, the mean number of CTCs were 13.8, with the range varying from 0 to 48. And there was a positive correlation between the number of sites of metastasis versus the number of CTCs, with a significant p-value of 0.001. These are the tables showing the comparison of PET-CT at the 3 months with the number of CTCs at the baseline and 1 month and at the 6-month interval. Here we can see this is and according to PET-CT, the patients were divided into complete responders, that is the responders group comprising of partial and complete responders, stable disease and a progressive disease. And the progressive disease, the mean was 7 CTC at the baseline, and after 1 month of the treatment, the CTCs were increased to 18.2 and with a significant p-value of 0.02. Similarly, in the responders case, it was 14.3 in the beginning and was reduced to 5.9, and the p-value was significant 0.003. After 6 months, again the CTC comparison and this comparison with the PET scan was done. And here also we found the significant p-value with the decrease in the CTC, that is it was reduced to 3 and from 13.6 to 15.1 to 3.1 and 3 with a significant p-value of 0.001. And at the end of the 6 months of the treatment, here we can see that the partial responders was 16 in number, and at the 1 month they were reduced. CTCs more than 5 were seen in only 8 patients, and at the end of 6 months only 5 patients had a CTC greater than 5. This is in Kaplan-Meier overall survival graph, which shows the statistically difference was noted when these groups were compared with 1 month treatment, and the patient was CTC less than 5 or equal to 5, with overall progression-free survival of 11.1 and 7.5. However, in terms of overall survival, there was no statistically significant difference was seen in these patients. Coming to the discussion, there are many studies which are being done on the CTCs on the metastatic breast cancers. So among this, was the one study which enrolled around 117 patients of metastatic breast cancers having a circulating tumor cells. And in this study, the results were the number of circulating tumor cells before treatment is an independent predictor of progression-free survival and overall survival in patients with metastatic breast cancers. However, they have also included the control subjects in their study, and they found that amongst the 145 normal subjects, only one case has greater than equal to 2 CTCs, and the benign breast conditions, out of the 200 cases, one case has greater than equal to 2 CTCs. So they have concluded with these results, with the CTCs present within the normal tumor, within the normal cells, that they concluded that the use of this assay as a screening tool to detect a new primary cancer or metastatic breast cancer should not be done. This is another study, very interesting study, where they have analyzed this is the clinical trial DETECT study group, where they have enrolled the 1933 patients, and they have seen the assay, HER2 assay status in the CTC. And they have found that the presence of even a single CTC with a strong HER2 staining was associated with short overall survival, supporting a biological role of HER2 expression in CTCs. Another, this is a review article from the lung cancer, where they have compiled all the studies done in the non-small cell lung cancer, but and most of them have found the similar results, except for the one they had said there is no significant difference. And other difference was some of the cases have taken a cutoff of greater than 8 CTCs, whereas most of them had a cutoff of greater than 5 CTCs. So here we see that different studies are being done, but there is a no there is a no cutoff which is being decided uniformly by all the people. Someone has said even if one single CTC is of a significant, which is HER2 positive, someone is taking as a 8, greater than 8 CTCs, and someone has taken, most of them are still now being confirming to the greater than 5 CTs being of a clinical significance. So to conclude, CTCs has a prognostic relevance in monitoring the therapy, and the assessment of CTCs provide a more quantifiable response than radiographic evaluation at a much earlier time point, and is also a better predictive of survival. And what is the current status and where do we need to progress? Liquid biopsy technologies are unaffordable in developing countries despite of the highest cancer burden, and there are certain clinical concerns like non-specificity of the test, low efficiency, long turnaround time, and the standardization of the process, which needs to be done by doing different studies. And parallelly, what can be the future? The parallel detection and quantification of different analytes at the same time. CTCs isolated with different systems can be cultured and can be used to study the drug susceptibility to generate the sufficient number of cells for systemic deep analysis. And this is the our liquid OncoCore OncoDiscover CTC comprehensive panel, where the 10 ml blood collection in BD Vacutainer K2 EDTA is being required, and the temperature is 4 to 8 degree in the cool pack. And the most important thing here is once we choose our X lab to perform this test, we should always perform the test from the same laboratory, because it is a screening of a therapy. It is we are just looking for the therapy, how the therapy is going. So it is always advisable to do the test from the one laboratory, because they will give the results of the over the period of time, comparative results. So these are the Equivocal panels available at the core, 52 gene panel and 12 gene panels. And this is our experience of 246 cases in non-small cell lung cancer. Yes, sir, it's done. And amongst these, 46% were most common. To conclude, a fully incorporate liquid biopsy into liquid praxis, some critical points need to be addressed. That is the best matrix of detection and technical approach is required for the application, pre-analytical standardization to obtain the robust and reproducible results. And still by end, liquid biopsy is a gold mine for the early diagnosis and effective monitoring of the treatment. Thank you, everyone.
Ma'am, due to want of time, we'll have to move on to the next session. So thank you, Mallika ma'am, thank you, Kavita ma'am, for the wonderful speaker talks. We'll now move on to our panel discussion. The panel discussion is on the topic EBC, when is adjuvant treatment required? And it gives me great pleasure to introduce our moderator, Dr. Shirish Alurkar, Senior Medical Oncologist from Ahmedabad. With sir's permission, I will also invite the panelists. Our panelists are Dr. Preeti Agarwal, Medical Oncologist from Jaipur, Dr. Kunal Jain, Medical Oncologist from Udaipur, Dr. Abhilash Mann, Radiation Oncologist from Udaipur, Dr. Saurabh Sharma, Surgical Oncologist from Udaipur, Dr. Dhaval Sharma, General Surgeon from Udaipur, Dr. Naveen Goyal, General Surgeon from Udaipur, Dr. Pawan Nikra, Oncopathologist from Udaipur, and Dr. Bharat Gupta, Intervention Radiologist from Udaipur. I request our panelists to please sit on the first two, in the first row. Yeah, over to sir.
Good morning. I think all of the panelists are here, or is anyone missing? Everyone is there. Anyone? Okay. So who is not there can raise their hand. Okay. Okay. So basically, when I discussed this topic with Dr. Manoj, he said instead of going for really into the therapeutics, go more into the diagnosis of early breast and the tests required for that. So what I'll be doing is stressing more on the diagnostic parts of the early breast cancer. So going to the case, this is 38-year-old well-read lady. She had a lump in the right breast since about 1 month, and the sonography showed a hyper intense, or rather you can say hyper dense mass at the 2 o'clock position with calcifications. The size is here. And she had few axillary nodes, and the chest X-ray were normal. Mammography showed a speculated mass. I'll show the image at about 2 o'clock position with about a couple of maybe axillary nodes. Sorry for the small print there. So mammography is the, I think we have the radiologists here. Mammography is the standard of care in breast cancer screening, and it has been shown to reduce the mortality. Everyone knows that. The sensitivity and specificity are little better than the a little less than the MRI, but MRI has definitely a role in certain subsets of patients as a screening modality, especially in patients with BRCA mutation. This was the mammography image, the typical mammography image of this patient. So to the radiologist, my question is, would there be any issues about mammography in this patient, the 38-year-old lady, young, would there be any issues of doing a mammography in this patient?
Can you take previous image back?
Okay.
Yeah. In this case, we are seeing that glandular tissue is very small in amount, but in female around 38-year-old, the one issue which we face during mammography is that amount of fibroglandular tissue hinders the appearance of the lesion if it is present. In that case, we should go for a correlation with the ultrasound, and definitely ultrasound plus mammography increase the sensitivity plus specificity of the diagnosis.
Yeah, okay.
Yeah.
Yeah, so
Shirish,
sorry.
can I make a comment?
Yeah.
So I think the high pedestal on which mammography used to sit 5 years back or 10 years back doesn't hold true anymore.
True, true.
There are some very big and large studies from Europe, particularly Scandinavia, which are seriously doubting whether mammography contributes to reduction in mortality or not. And I would seriously question why a mammogram was done. Radiation exposure to the breast was done in a patient who was less than 60 years of age.
Yeah. So that was I was going to come. So this patient came already with the film. Usually the patients come with the film. So that's what I wanted to ask the radiologist. Would there be any issue of doing a mammography in this patient? Does it really have any validity of doing in a 38-year-old lady?
Definitely, it should be done in
should be
around 4. No.
Okay.
Ideally, it is indicated in elderly females around 40 to 45 years.
40 plus.
40 plus. In young females, glandular tissue is a hindrance, and we have to take anyhow help of sonography to make more confirmative diagnosis.
Okay. You want to add anything, Malhotra? Okay, sorry. So, is there any?
Just wanted to make a point for the younger colleagues that every patient 20 years, 30 years should not be sent for a mammogram. Do a sonomammogram, right? So you don't expose the
This was
breast
only
to
a
unnecessary
mammogram.
radiation. Yeah.
Small point again, mammogram help us picking up multifocal lesions, which is very difficult in picking up sonography, especially if you are planning for BCS. Just a
Yeah,
my
there are
thought.
other modalities for that. Okay.
Yeah, one more thing, exposure factors do matters. If there are poor exposure factors, we might miss micro-punctate calcification. They are difficult to appreciate. So technique
Yeah.
do also help in such cases. We do need to change the factors to bring a better mammogram.
Okay. Yeah. So coming, just go ahead. Is there any pitfalls of doing a mammography in Indian females? Say, anything different between the Western literature and Indian females? Say, based on the densities or anything different on that?
As such, I don't have much experience on that part yet. Yeah, in my experience with Indian females, what I have to repeat again that elderly female making diagnosis is easier for us as compared to a younger female.
So there is some data. I don't know, Dr. Malhotra or Usman. There is some data which there that Indian breasts have more density. They are more dense compared to Western population. So, but I went through the literature. There's nothing really published there. One or two reports, I think, from PGI, where they have said that overall the Indian breast, the young females are more dense. Therefore, it's difficult for a mammography to really get any information. So, of course, we are not going to this screening mammography. Not doing. Yeah. So, any role of MRI in this patient, and how? And then we ask the same question to the surgeon.
Yeah, in MRI, definitely, if there is any suspicion and we are not getting the diagnosis before going for biopsy or any histopath checkup, we can go for MRI screening. MRI screening with contrast and that curve mammogram. If we go for a dynamic study, we have few factors which help us. But in true manner, in practical way, it is very difficult to do a good curve mammogram on MRI, and definitely it will add more towards the diagnosis in doing MRI.
So, would the surgeon just go ahead with surgery, suppose, and or ask for an MRI in this case? And how will it help him in, say, planning the treatment or any other prognostically or anything?
For this particular case, there is no dense breast as such we have seen on mammography. So I don't think MRI will add on something in this case.
Okay.
Especially in
Yeah, Dr. Malhotra, I want to add something.
So I think one small point which all of us need to keep in mind is that this is not a routine MRI. It has to be done on a breast protocol with a breast
dedicated
coil.
Yeah, dedicated coil.
Right. So if the center is not doing regular breast MRs, then there is no point in asking for an MR. So that needs to be kept in mind.
Technique is very important.
Yeah. So, in one of the clinical outcomes which could be affected as far as surgeons are concerned is the conversion of an MRM to possibly a BCS after, say, therapy. Re-excision rates, these are the literature there. The detection of contralateral disease. So, you are planning to do one side, but you find something on the other side which may be missed on a mammography or a sonography. And to detect local recurrences. So, this is how probably an MRI is better in a way than mammography to plan for surgery as far as the young early breast is concerned. And this data has been confirmed by two studies. One is the COMIS trial, all of you know, another one is the MONET trial. I don't know if it's visible or not clearly, but if one sees on the left side chart, the COMIS trial, initially all these patients were planned for BCS, but ultimately 7 patients 7% patient underwent mastectomy based on the MRI results. So there were some findings with the surgeon then converted to this. The total mastectomy, if you see on the bottom part of the chart, total mastectomy about 13% in the MRI versus the patient didn't go MRI was at 9%. But the re-excision rates again were equal. So whether you do an MRI or not, the re-excision rates were almost equal. So that again brings the question whether MRI is really useful or not. But here there was a problem with this study because the radiologists were not really conversant doing an MRI. So they didn't have that much experience doing an MRI. Probably a new study, better study nowadays may help to solve this issue. Yes?
Yeah, good MRI machine availability is also an issue in Indian scenario because in many centers, good MRI machine, we need to do a dedicated MRI for a breast. And as said that dedicated breast coils availability, those are very costly. So very few centers are having that. And one more point, just as a part of discussion, I just need to bring on part of radiology. Can you bring first slide in front?
First slide you want?
Yeah.
Okay. This one?
Before this.
Yeah.
Before this.
Is there
Yeah.
history?
You mentioned just bringing into the knowledge of the all doctors that in sonography we used to have a term like hyperechoic. Echoic is the term which is used for sonography. For CT it is dense, hyperdense, hypodense, and for MRI we use hyperintense.
Yeah, there was a
for
typographical error.
yeah. So just to bring into the notice that
Agreed.
yeah.
Accepted. So just go ahead with the case. The true cut biopsy showed infiltrating duct carcinoma grade 2. So now medical oncologists on the panel, we have I think one medical oncologist. Yeah. So what would you do next year? Of course, this is the IHC. Anything further than this?
So IHC, yes. And then we need to do the staging workup. The early stage breast cancer, chest X-ray sonography is more than sufficient.
Okay.
And if the patient is early stage and wants to go ahead with the surgery, then surgery.
Okay. Anything anyone like to add more to this investigation? Anything? Would the surgical oncologist were to add something?
I think she is young female with clinically node positive. As per guidelines, there is no role of PET-CT right now.
Okay, so you will not do a PET-CT.
But I will like to do a PET-CT in young patient. I want to be more aggressive in this patient.
So does your decision for PET-CT depend on the age of the patient or the biological characteristics?
Biological characteristics, node positive and young age. All.
Okay. Anyone would like to differ in the audience?
How many percentage you find PET-CT useful in this kind of situation?
Actually, by guidelines, there is no role of PET-CT. It is based only on clinical symptoms.
It's a period. You know, the PET-CT is something which is very, very limited role in early breast cancer.
I mean, you can sometimes have something in the mediastinum, time, then you find out there's a node. It comes out to be maybe tuberculosis. That may be one of the situation. Maybe.
Before going surgery, what should we do? Either go for FNA or biopsy or directly?
No, I mean this patient hasn't gone to true cut, so it's already done.
Only FNA?
FNA based, no, that's totally out of the thing. If there is an axillary node, you want to see whether there is a metastasis, maybe an FNA of the axillary, if you don't have a sentinel node biopsy facility. Yeah, genetic profiling, medical oncology, would you do for this patient?
So do we have any family history of breast cancer in this patient?
No.
So we don't have family history, even though the young patient, HER2 negative, hormone positive, yes, I would like to go for genetic profiling.
Which is like?
Which is HRR, or BRCA1, BRCA2 and other HRD mutations.
Okay. So we like to do for HRD straight away. So
yes.
would HRD give any, additional information as far as therapeutics is concerned?
Yeah, in maintenance, yes.
So maintenance treatment like what, for example?
If BRCA positive, then yes, maintenance olaparib.
But so why not just do an limited thing like only BRCA1, 2, rather than going the ATM or the PAL-B2 or whatever, RAD, which is the HRD.
Yeah, prognosis.
Okay, so prognosis. Anyone else? So Dr. Malhotra, do you do a broad gene panel or do you just do BRCA1, 2 and then?
So I would send this patient for surgery, either breast conservation if possible or MRM. And I would do a BRCA1, BRCA2 because of the age of the patient, not because I would give her any adjuvant PARP inhibitor, but because I would want to counsel her for disease in the opposite breast and her family.
I'm coming to that, yeah. So, okay, this was the test. It was a wild type. We have gone to the question of broad genomic profiling. This patient underwent a BCS, axillary lymph node dissection. Final histology was this. It was PT2N1, ERPR positive, HER negative. So, coming to the adjuvant therapy now. So, what adjuvant radiotherapy, because it's a BCS, radiation oncology, please. Yeah, sorry.
Actually, in this patient, you have mentioned that BRCA1, BRCA2 is positive.
Wild type.
Okay, wild type. Sorry, I missed that.
Wild type, wild.
As we can see, the patient is young lady and treated with BCS. So we treat the whole breast irradiation with hypofractionation dose schedule. That is 40 grain 15 fraction, followed by a boost to the lumpectomy site with a dose of 10 to 16 grain 4 to 8 fraction to reduce the local recurrence.
So boost you give to all patients with
mainly, sir, main benefited group of boost is younger age group, less than 50-year-old female, margins are positive and high grade tumor. That one the most
and
benefited.
Nowadays you go for a standard hypofractionation.
In BCS patients, sir.
In BCS.
In
okay,
BCS
okay.
patients.
In this
sir.
patient, I was saying.
Yes, yes, sir.
Okay.
Shirish, can I request
Yeah,
you to do an audience poll on one question which bothers me? Suppose an MRM had been done in this patient. So how many of us would want this patient to receive adjuvant radiotherapy? One node, grade 2, ERPR positive. Would everybody want radiation to be given adjuvant setting?
To the audience, yeah.
You asked the question.
Okay. Okay, so the question is if the patient instead of BCS would have gone MRM upfront because the patient had landed to a surgeon first. So MRM upfront, this was the histology, it remains same, right? So any role of adjuvant radiotherapy you said, yeah. One node positive.
How many would give adjuvant radiotherapy? Show of hands.
Show of hands, yeah.
So can you do the count? I mean, I don't want to turn it around.
Raise your hands again. 1, 2, 3, 4, 5, 6, 7, 8.
And how many would not give adjuvant radiotherapy?
So one node.
So what is the majority?
Not.
Not. So most of us are, kind of, inclining towards the European guidelines and not the American guidelines. Right. But कुछ Americans भी हैं अपने अंदर, ना?
Yeah. Okay. What adjuvant systemic therapy would you advise to this patient, the medical oncologist?
Young patient, T2N1 node positive disease, doxorubicin based doxorubicin cyclophosphamide followed by paclitaxel based therapy, taxanes.
So you
as
want
well
to
as
the dose dense sort of 4 AC followed by
4 pacli.
Okay. So why not just we are going too much in technique. Why not just 6 cycles of say AC or EC? Another next question is, can we omit anthracycline because this patient is going to live for long? She may end up with a cardiomyopathy. I've seen cases where I've treated 2 or 3 years back. Patient comes after 2 or 3 years with breathlessness, and we have done 1 or 2 echocardiographies. Initially it was normal. Then she comes after 2 years or 3 years with a cardiomyopathy. So would you like to do away with anthracyclines or?
No, I would not like to go away with anthracyclines.
You still believe in that?
Yes.
Dr.
Yes.
Manoj, would you use anthracyclines here, or are you a non?
It's early stage, low young patient, and ERPR is positive, HER2 is negative. So I would like to use anthracycline subsequent if required. Upfront we can.
So means second line.
Yes.
Okay. So you will mainly be taxane based or therapy first line. Okay. Fine. Yes,
Shirish, can you do me a big favor and ask if this patient was 60 years old, then what would be the adjuvant systemic therapy approach?
Then I would like to omit anthracyclines.
You like to omit anthracyclines.
But you would still like to give chemo,
Yes.
Preeti?
Yes. I would like to.
You would like to do a prognostic score on what?
Score,
Yes. Since she is not
Bolo
positive.
Bolo, why don't you say that?
I was coming
She is
to that
not
actually.
positive. Yes.
Okay. So this was the this is the basic NCCN guidelines. So if the patient has a very early stage, I mean early stage, we can say, you determine whether patient is a candidate for chemotherapy or not. If not, go for adjuvant endocrine therapy with ovarian suppression because she is premenopausal. Otherwise, go for a standard endocrine therapy with or without chemotherapy, depending on your tumor board. Now the question to surgery is going back slightly. If this patient came with a report of BRCA mutation, would your surgical approach change?
BRCA mutation, there's role of prophylactic mastectomy also. So
The mic is not working. I think, yeah.
So I will suggest the patient for prophylactic bilateral mastectomy and also salpingophorectomy.
Okay, so let me ask you another question. How many patients you counsel, let's say theoretical out of 10, accept contralateral mastectomy? In an Indian setting, it is difficult.
Yes, sir, it's difficult.
Okay, they may accept oophorectomy because of the consequence of using an ovarian function suppression injectables. Every monthly, they may accept an oophorectomy, the family is okay. But doing a contralateral mastectomy, anyone in the audience, anyone would like to add on to it?
So I think a more basic question is that for a BRCA mutant patient, how would you address the primary disease? Are you comfortable with doing a breast conservation and doing radiation in a genetically unstable patient, or can you still go ahead and do breast conservation and radiation?
No,
that is the
question, yeah. So you can answer that.
I like to do mastectomy for this particular site.
Okay.
Dr. Saurav, how frequently you have advised patient for oophorectomy in this kind of situation and contralateral mastectomy, as you are saying?
I have done 2-3 cases like that, not here. And my previous
Contralateral mastectomy?
Yeah.
All right. News to me.
Actually, in these kind of patients, the best approach is to do the bilateral mastectomy and bilateral salpingophorectomy, followed by reconstruction of bilateral breast. That is the standard recommendation in BRCA1, BRCA2 positive patients from a surgical point of view.
Agreed. These are the guidelines. So if you really see ground level, very difficult to do it.
I differ completely. These are not practice in Indian scenario.
Few days back, I have operated one.
No. You are doing is fine. You know what I'm saying is, when we talk in conference, we should give message which is practicable, which should be done routinely, and it should not confuse the mind of.
And as per my opinion, this is practical rather than
All
waiting
right.
for the
Thank
other
you.
side to develop.
All right.
It
Okay,
is
so
always
thank-
better because the risk of
All right. Okay. All right.
we should
Okay, so-
always counsel the patient. Now it's patient's choice whether they want to go for it or not.
I want to ask a question. When the patient has undergone breast conservative surgery and BRCA mutation test comes out to be positive later on, do you then also advise completion mastectomy after that, after completion? So one of my
Yes.
patients during chemotherapy, BRCA1 has come out to be positive. The patient has undergone breast conservative surgery.
Yes.
So
We should advise. Our opinion should be like
then
this only.
then also bilateral mastectomy.
Yes.
Okay, so we'll just go with, we have about 3 minutes remaining. So this was one of the studies which was published in Annals of Surgical Oncology, where they decided whether there is an impact of timing of genetic mutation and the surgical decision. So if it just focuses on your right side, this chart here, the blue is the contralateral prophylactic mastectomy and the reds are the ipsilateral surgery only. This could be an BCS or a mastectomy. So whenever the mutation status was known prior to surgery, most of them, about 75%, had undergone a contralateral prophylactic mastectomy. This is all European data, so it's difficult to do. But this is just a theoretical to say that BRCA mutation has an implication in surgical decisions. So the aspects to be considered before doing a surgery are whether there is a risk of ipsilateral IBR recurrence, a contralateral breast recurrence, or a potential survival benefit of a prophylactic mastectomy. So, and if the patient has depend on type of mutation, again, if it's a BRCA1 mutation, a more aggressive disease, probably you have to go for a more aggressive surgical approach. If it's a BRCA2, an older patient has received adjuvant tamoxifen, maybe you can slightly be a little on the back foot and give slightly more conservative treatment. Genetic profiling, just one line, yes or no in this patient? You not do it, okay, fine. And any other you will do Dr. Malhotra in this patient.
Genetic profiling, you mean recurrence score
Recurrent,
assessment?
I have mentioned oncotype DX, yeah, for a mamma print.
So I think for a young patient with node positive disease, I'm going to give her chemotherapy as it is.
Yeah.
But if this patient was postmenopausal, 60 years old, then this is the first thing I would do. And then on this, maybe discuss with the patient and decide chemo or no chemo.
Okay.
But certainly adjuvant hormone therapy.
Fine. So I think I'll just skip to, so oncotype DX and mamma print are the only two genetic profiling GEP, they say, platforms which are approved, and they have a level 1A evidence in various indications here. And I will not go into this. So
I think, Shirish, we should also mention that there is a Indian platform now available,
yeah.
which is known as CanAssist. Maybe not, it is validated in more than 1,000 Indian patients. Maybe not made it to the international approval, but most of us needs to at least consider that.
yeah.
Turnaround time is less than 2 weeks and it costs only 60,000 rupees.
60,000, yes. How many of you is using CanAssist? Even I have used it, yeah. Okay. You want to add something?
So do you routinely do for the elderly patients, node positive, CanAssist? Do you think ERPR, Ki67, the 4 markers are not sufficient?
So,
Parik can take that.
yeah, yeah. Thank you. CanAssist is used irrespective of age. Okay. Unlike oncotype DX, there is no difference between younger and older patients. So if I decide to do, it will be irrespective of age. If your question is that is the other conventional test sufficient to arrive at the diagnosis, I mean the risk categorization, I think no, that's not enough, and therefore I would prefer to do CanAssist. And published data in international journals has shown that if you follow that, 67% of women will be prevented from receiving unnecessary chemotherapy, and that is the greatest takeaway that I have.
Thank you, sir.
Okay, so I think this will be the last slide. So in premenopausal women, as in this case, oncotype DX can be used in patients with node negative, ERPR positive, HER negative early breast. There is an insufficient data as far as the node positive disease is concerned. So maybe we have to probably go for a chemotherapy in such cases. In patients with more than 4 nodes, obviously we don't do any gene profiling. The patient is straightforward for chemotherapy. I think that's it. Time is up. Thank you very much. Thank you.